Lumbopelvic fixation, or LPF, is a crucial technique for stabilizing the lumbosacral junction in cases of trauma, tumors, and other pathologies. While minimally invasive percutaneous techniques are preferred when feasible, open LPF remains necessary when direct sacral access is required. We present a case of sacral metastases and describe a refined surgical technique for open LPF, developed to minimize invasiveness while ensuring robust and reliable fixation. A 56-year-old woman with a history of breast cancer developed progressive pain in the left gluteal region, radiating to the ipsilateral thigh. Imaging revealed a metastatic lesion extending from S1 to S3, infiltrating the sacrum and compressing nerve roots. Following further investigation, no other pathological uptake was seen in a whole-body 18F FDG PET CT scan. Biopsy revealed metastatic involvement from mucinous breast carcinoma, and a chemoradiotherapy regimen was started. Despite radiotherapy and systemic therapy, her symptoms worsened, leading to urinary retention and radiculopathy. Further MRI imaging demonstrated lesion growth. During a CT scan, signs of pathological multiple sacral fractures were found. Given the extent of tumour involvement and neurological compromise, surgical intervention was planned, comprising lumbopelvic fixation combined with nerve root decompression and intralesional tumour resection. The operation began with the patient in the prone position under intraoperative CT navigation. A linear midline incision from L3 to the sacrum was made. Dissection was minimized to preserve the paraspinal muscles. Lumbar screws were inserted in L3 through L5, while iliac screws were placed bilaterally, using a supra-fascial approach with limited exposure of the posterior superior iliac spine. A subfascial tunnel allowed the passage of pre-contoured rods, which were connected to the screws. Sacral laminectomy was performed for decompression, and the tumour was removed intralesionally. A U-shaped crosslink was added to enhance construct stability before layered closure. The procedure lasted about 250 minutes, with an estimated blood loss of 180 millilitres. Postoperative imaging, including standing X-ray and photon-counting CT scan with 3D reconstructions, reported satisfying results. Postoperatively, the patient had no new neurological deficits. Her urinary function gradually recovered, pain decreased from a score of 8 out of 10 to 2 out of 10, and she was discharged 10 days after surgery, walking with lumbar support. At 6-month follow-up, imaging confirmed stable fixation and a stable residual sacral lesion. This case demonstrates that the modified open lumbopelvic fixation technique can achieve both stability and reduced invasiveness in managing complex sacral fractures. The patient's favourable recovery and resolution of acute urinary retention highlight the potential of this approach as a viable alternative when percutaneous techniques are not feasible.